kneecap. The whole idea of the kneecap is to increase the lever arm of the quadriceps. So your quadriceps that you're working so hard on is an extensor for the knee.
Right.
That's why the physio was asking you all those questions about sand, hills, driving. All of that is a lot more bend and a lot more pressure between your kneecap and your femur. In the old days, when people were having these problems with the kneecap, we used to remove the kneecap. It's called a patellectomy. So we would take the kneecap out so that you would still have your quadriceps functioning, but you wouldn't have pressure between these two bones. Many times that helped the pain, but not the strength, because this acts as a lever arm. So if you have a wheel that's flat and you want to change the tire and you put your spanner on and you can't loosen the bolt, you put a little pipe on, increase the lever arm, and with the same force you get more torque. It's the same with this. You're getting a greater lever arm on your extensor mechanism of your quadriceps, but the thing is you get more pressure between them when you exert it. So if you're walking on level ground, there's not a lot of pressure between your kneecap and your femur. But as soon as you go to that position,
yes,
this increases the strength of your quads, but in order to do that, the pressure goes up between these two bones.
Exactly.
Okay. So in your situation now, we've got a very functional knee replacement. It's put in well. The implant is fixed. The alignment is good. It's bending extremely well. Firstly, because it was put in nicely, and secondly, you are obviously very motivated and driven, and you've got ligament laxity, so you've got a very nice bend. The deeper your bend, the more the patella moves down into the prosthesis groove. Okay, so the greater the bend, the more likely to have patella problems. Now, when you look at that X-ray on the side view, you'll notice that the patella is not the same thickness throughout. Your patella at the top or proximal part is thicker. The patella on the distal part, the lower end of the patella, closer to the foot, is thinner.
Right.
That's why at the surgery, when you measured with a caliper 12 mils, if you've got to take off 10 to put in 10. Because the plastic dome that we fit in is normally around 10. It depends on the size of the patella. So if you don't resurface, it's a bit safer. If you resurface, with a thin patella, you could make it too big, and then they have even more pain. It's called stuffing of the patellofemoral joint. So sometimes we don't resurface the patella because we could make things worse.
That explains a lot.
That explains why he vacillated between the two. Because it's a grey area. Most of this prosthesis is very patella friendly. So we normally don't have to resurface the patella. In your case, the tracking of the patella is surprisingly very good on the prosthesis. Your angle between, it's called the Q angle, between your quadriceps, the patella, and the insertion of the patellar tendon on the tibial tubercle, the tracking is actually good. You can go and resurface the patella now to help with the pain, but 50% of those patients improve, 50% don't.
That's what I was told,
so
right?
It's very difficult to actually advise a patient on that. It's very difficult to advise a patient on that. It's one of the problems we have with prosthetic knees. We've actually come a long way in the last 2 decades on knee replacements, the design of the knee replacement. It's such a it's called a condylar joint. It's such a complex joint because of this little number here. If it wasn't for the kneecap, we would have way less headaches in our orthopedic clinic. But the kneecap, especially in ladies with flat feet, ligament laxity, and a deep bend, they're very high risk. And your asymmetric wear means you've had a patella wear since a young age, because it's thicker there, thinner there. That means it's just the way your alignment is designed, it's wearing the kneecap.
Now my left knee dislocated probably 6 or 7 times from the age of 11 through my high 20s.
So that would have been a kneecap dislocation.
Yes.
And that's what I said to you earlier about the ligament laxity with the MPFL, medial patellofemoral ligament, gets stretched with ligament laxity, and also then that's why it dislocated. So those patients are at high risk for patellas. And the whole aim is to get a nicely balanced knee replacement that will deep bend like you. That's phenomenal bend. I also get patients that do this, but we get excited when we get a mechanical knee bending this beautifully. That means technically you couldn't have done the procedure better. The problem is it puts more pressure on the kneecap the deeper it goes into that groove.
Exactly.
In a situation where you've got all the risk factors for patella pain already. You see, that's the problem we have. So where do you go from here? Statistically speaking, about 15% of patients, that's a lot, that's 2 in every clinic that we see, have got a kneecap problem before and after knee replacement. Doesn't matter what you do to the patella. So you can do activity modification, so you work around the kneecap. So the exercise, try and do a lot of walking level ground, you have to use the arch supports, and then sometimes you can strap it over, those sportsman straps to try and take the pressure off the kneecap.
You mean the K tape?
Yeah,
I use it every day.
Yeah, so there's all those things that you can do with occasional, some of my patients will take anti-inflammatory twice a week so they don't live on it, or take some of the natural anti-inflammatories out there, just everything to try and get the best out of what we have.
I take inflammatories a lot more than twice a week.
Yeah. So I mean, those are things that we have to look at. If it's still not acceptable for the patient's lifestyle and they have to do something about it, then you would go in and resurface the kneecap. Technically, what that means is you're going to end up with a very thin. You have to take enough bone away to get the button in, and technically you just got to make sure you don't fracture the kneecap, but you can go and resurface it. And then we still don't have any data to say it will help. We generally will quote some studies saying 50%, but I think you've got to weigh up that whole risk, because you've got to open that whole knee again to do it. And it is possible, but there's no guarantee that it's going to make a huge difference.
And just to sort of run this by you, one of the doctors I saw, consulting physician, said it was, he portrayed it as 30% of people actually get better, 30% of people don't experience any change, positive or negative, and 30% are actually worse.
Yeah, look, we all, I think it's in the detail. It's not necessarily exactly 30.
Yeah, but how many people, in your view, are worse?
Yeah, I think that the ones that are worse is when we don't take enough bone away. See, I really believe that when you're addressing the patellofemoral joint, you have to decompress it a bit. So instead of removing the patella, which will take out that pressure, I go really thin on the patella and put a button in, so that the overall thickness of my patella is 2 mils less than what it was before I started it. That's my personal conviction, decompressing the patellofemoral joint. I also do, some of the French do this, do a lateral facetectomy, where I take a little bit of that lateral facet away, which takes the pressure off. So I do a little bit of a soft tissue alignment and resection. So these are technical things, and I think that's what's going to determine.
So what are your results?
So we don't do enough of these to say, but I generally decide on the table, if there's enough damage to the kneecap, then I will resurface it. I'll take a bit of the lateral patella away, at least 7 mils, I cut that off this way. Then I resurface it and make sure that the total kneecap is less than it was before. It's not what the books will say, you kind of replace what you take away, but that's my approach to decompress the patellofemoral joint in patients who have had long-term problems like you have.
And how does the recovery compare to a total knee replacement?
It's a bit quicker because, but you have to open the muscle again. So you 4 to 6 weeks, but it is easier than after a full knee.
And would you do both at the same time, or do one?
No, I think that's very dependent on the patient.
Well,
when I do knee replacements, I don't do both at the same time. I did that many years ago, but the studies have shown higher risks of infection.
Oh, I wasn't technically the same time, but I might as well have been.
Yeah, you did it a month month ago. A month apart. I normally do it a little bit tighter.
I wish I'd waited a year.
Yeah, it's hard. It's hard to do it a month apart.
Because I lost all my muscle.
Yeah. But you didn't do them together on the same day, which is the right thing.
No, he doesn't do that. No.
That's good.
Yeah.
I think with what you've been through, you would rather do, because you have to open up the quadriceps, I would say do one and make sure that you're happy with that and it's
Right.
working. It's easier recovery, lower risk of complications, easier to mobilize obviously afterwards, and then you can rehab it slowly and do your thing, and then see what it does. And if you're happy with it, then you do the other side, rather than, you know.
Who knows? Maybe I could learn to live with one knee that's able to be more fully functioning and the other one not. You know, it's not like I'm doing any races or anything. I'm a very intensive gardener, and I can't garden.
Yeah, but after knee replacements, a lot of people can't go onto their knees. Your flexion is actually remarkable, so that's in your favor. But like I say, that puts pressure on the kneecap.
Oh, I can't. I mean, I can do it. It's not comfortable to get down on my knees.
So most people will use a small pad.
Yes, that's what I use. Yeah.
Things, put a canvas cushion there in the garden, and you can do that. So a lot of stuff to think about.